Well, thank you very much, Imogen, for the invitation to talk to you all this afternoon. And thank you for bringing the Melanoma Conference to Hampshire. So I'm an oncologist in Southampton. And it's a pleasure to have all of you here. So I'm going to talk about adjuvant therapy for high-risk melanoma. Now, one of the problems with being one of the later speakers in the afternoon is actually a lot of what I'm about to tell you has already been said. So some of this is going to be revision. So I'm going to slightly digress before I get onto the main subject. First thing to say is that we've talked a little bit about bias and some of the statistics talk, so I've got some disclosures. So I have worked with some of the pharmaceutical companies which have sponsored a lot of the trials that we've talked about. My other disclosure is that I've been a melanoma patient. So 18 years ago, I had a stage 1 melanoma. And so it's quite interesting listening to Julia's talk, because I think I ticked every one of the boxes in terms of risk factors. And with my current sun avoidance experience, I'm going to die of a heart attack, I think. But it does give me, I think, an interesting insight into statistics, particularly when we're talking about risk of recurrence. And I think that's really important when we're talking about adjuvant therapy. So in terms of what I'm going to cover, I'm going to talk a little bit about what adjuvant therapy is, because I think not everybody understands what that is. We've talked quite a lot about survival curves, but I've just got some examples of those, and then go through some of the trials which have been recently presented looking at various adjuvant approaches and some of the ongoing unanswered questions. So what is adjuvant therapy? I'm not a complete technophobe, but rather than doing what my kids do, which is go to Google, I did at least dig the dictionary out and looked in the Chambers dictionary at what the sort of definition of adjuvant therapy is, or rather what the definition of adjuvant is. And the dictionary says this is something that helps, and in particularly in the context of medicine, then perhaps a substance added either to a medicine or other treatment to improve its effectiveness. And in the context of oncology, what we're usually talking about is some sort of drug therapy or perhaps radiotherapy added on to definitive management of the original tumour, which is usually something surgical, to increase the likelihood of longer-term cure. So as Dr. Nathan mentioned earlier on this morning, so if a patient is diagnosed with a high-risk breast cancer or a high-risk bowel cancer, they will be often offered some chemotherapy as a backup to their surgery to minimise their risk of recurrence. Until recently, we just haven't had the active drugs in melanoma to provide that benefit, but clearly times are changing. One of the challenges of adjuvant therapy is defining who will benefit from it. So the results of adjuvant trials are all based on populations of patients. So we can say that for a group of 100 patients, some of those patients will relapse, but not all. And by treating all of those patients, we may be able to reduce the number that relapse. But of course, some of those patients were never destined to relapse and will have had treatment that they never needed. And some patients will relapse despite the treatment that we've given. And what's really difficult is explaining to an individual patient where they fit into that. And so having conversations with patients about how they know they will benefit from an adjuvant approach is very difficult, because actually there's no real way of telling that. So if a patient has surgery and adjuvant therapy and in the long term they don't relapse, were they ever going to relapse? Is it the fact that they were going to relapse and have benefited from the adjuvant treatment? We just don't know. So we've looked at lots of survival curves. So, and I've just got a few illustrations of survival curves across different cancers. So this is the sort of survival curve that we quite like to see. So one of the other things that I treat apart from melanoma is testicular cancer. And testis cancer is really very sensitive to chemotherapy, and so almost all of the men that I treat with testicular cancer, however far it's spread, are ultimately cured. And so if we look at their survival curve, we can see that all of the patients, when they start their treatment, are alive, and actually, if we go out over time, and this is a scale measured in years, 20 years later, over 90% of those men are still alive and well. This is the sort of survival curve that we don't want to see. This is a survival curve based on the treatment for lung cancer. So the first thing to say is we've got a different scale across the bottom, so we're now looking at a period measured in months, and can we see that very quickly, over time, patients succumb to their disease. And what we want to do is find treatments which is going to take this survival curve and turn it into this survival curve. And though this is a curve that we've already looked at in earlier talks, looking at where melanoma sits at the moment in the metastatic setting. So this is from the Keynote 006 study looking at pembrolizumab versus ipilimumab, and really showing something in between. So again, we've got a scale measured in months, all going out to 24 months there, and we've got about half of patients still alive at that stage. But clearly, we've got a long way to go to reach something like this. So adjuvant treatments specifically, so there's now a number of trials to talk about. So interferon's been mentioned earlier on as a slightly old-fashioned treatment, but with some uptake in other parts of the world, less so in the UK and Europe. And then more recently, more active drugs in the metastatic setting that have now been trialled in the adjuvant setting, so ipilimumab, nivolumab and pembrolizumab, the PD-1 inhibitors, and then also the targeted therapies, dabrafenib and trametinib. So I thought I'd look at each of those in turn. Starting with interferon, which is a really controversial approach. There's been lots and lots of trials done over probably decades now. All of those use slightly different dosing schedules. All of them use different durations of treatment, and unsurprisingly have shown fairly different results. A summary is probably that there is a marginal benefit in a small proportion of patients, and there's some hint that it may be particularly patients who have ulceration of their primary tumour that might benefit from interferon. So this is a graph of a combination of trials done by the EORTC looking at adjuvant interferon, and they specifically looked at what the benefit of treatment was in patients who had ulcerated or non-ulcerated tumours. And the top two curves are patients who had non-ulcerated tumours, and actually the patients who didn't have adjuvant interferon did slightly better than the patients that did, so clearly not the result that you'd be looking for. If we look at patients who had an ulcerated tumour, then actually here there does start to be more of a significant difference with the interferon patients doing better than the non-interferon treated patients. But this is at the expense of significant toxicity. So being on interferon is not much fun. It gives you fevers, thyroid dysfunction, there's an instance of depression. But now, of course, we've got more active drugs in the metastatic setting. And the first of those to be trialled adjuvantly was ipilimumab. So this is a study which was done quite some time ago now, looking at ipilimumab, and interestingly at a slightly different dose to that we use in the metastatic setting. So when we give ipilimumab either in combination with nivolumab or by itself, we give it a dose of 3 milligrams per kilogram. In this trial, it was given at a dose of 10 milligrams per kilogram, and there is a dose response in terms of how effective the drug is. So the bigger the dose, it probably is marginally more effective, but equally the toxicity goes up as well. So patients in this trial received 4 doses of ipilimumab in a standard way every 3 weeks, but then went on to a period of maintenance, so they could have treatment up to every 3 months for up to 3 years. And this was a placebo-controlled trial, so it was done in an era where, certainly in the UK, adjuvant therapy wasn't being offered. This is for patients with completely resected stage 3 melanoma. So this is melanoma which has spread to nodes but completely removed. But it particularly addressed a slightly higher risk group of stage 3 patients, and it was only those who had at least a millimetre-sized deposit in their node if it was microscopic spread. It's a big trial, so nearly 1,000 patients recruited, and it ran across Europe, North America, and Australia. And this is the outcome. So this is the survival curve showing a definite benefit for treatment with ipilimumab. So again, we've got long follow-up for this trial, so our scale along the bottom there is measured in years. And we can see that at 5 years, the likelihood of being alive is around 10% higher with ipilimumab rather than with placebo. But of course, that means that 54% of patients are treated with this drug who actually never needed it, because those are the patients who are going to be cured by surgery alone. And that's particularly important when we look at the toxicity, because this is not a straightforward treatment. So we've heard quite a lot about the potential toxicity of immunotherapy, and if you give ipilimumab at a dose of 10 milligrams per kilogram, it almost mirrors the side effects of giving ipilimumab and nivolumab in combination. So we talked a little bit about grading of side effects. So grade 3 or side effects, the sort of 3 or 4 side effects, the sort of thing that might land someone up in hospital. We're seen in 40% of patients in this trial. And in fact, 5 patients died in this trial from side effects of their ipilimumab. And that's really critical, because these patients may have been patients who were cured of their melanoma before they were even exposed to the ipilimumab. So clearly we need a less toxic but equally effective alternative. And of course, we know now that in the metastatic setting, then we've got that available. So we've got nivolumab, PD-1 inhibitor, which we know in the metastatic setting is more effective than ipilimumab, as we saw in the trial earlier on, and with a much lower incidence of side effects. So a similar study this time, rather than having a placebo, we got 2 treatment arms. So half of the patients in this study received ipilimumab, again at that high dose of 10 milligrams per kilogram for up to a year. Or they had nivolumab at the conventional dose, 3 milligrams per kilogram every fortnight for up to a year. And here there was a double placebo, so because of the different in scheduling of the 2 drugs, in order to ensure that patients didn't and the clinicians didn't know what they were having, if you're having ipilimumab, you got placebo nivolumab. If you're having nivolumab, you got placebo ipilimumab. So lots of toing and froing to the clinic for this treatment. And again, this was a slightly different population of patients. So here we've got stage 3B patients rather than the stage 3A with the 1 millimeter focus. So effectively that means either the patients had an ulcerated primary or the node was clinically apparent, so you could detect it and feel it, or more than one node involved. And it also included this group of stage 4 patients, so our slightly higher risk group where the melanoma has spread to a distant site but could still be managed surgically. Again, big study, 900 patients, and an international trial. So this is a slightly different results curve in that here, because the data is a little bit younger, so this was a much more recent trial, then we don't yet have the survival results for this study. So this is relapse-free survival. This is the time to patients getting recurrence of their melanoma. And again, we talked earlier about how there are some patients who we don't have complete data on who are marked by these circles. But nonetheless, I think we can see a convincing improvement over ipilimumab with the green line, with nivolumab with the blue line. And so we have a positive hazard ratio of 0.65 and a very highly significant p-value of less than 0.001. So I think there's little doubt that nivolumab provides additional benefit over ipilimumab, and we already know that ipilimumab provides a survival advantage over placebo. And in terms of toxicity, well, this is a much more attractive approach. So we have around 14% of patients getting this higher grade treatment-related side effects. And actually, whereas the side effects of ipilimumab are often driven by things like colitis, often the side effects of nivolumab are less symptomatic, so things like blood tests that patients may not be aware are going on. And importantly, there were no patients who died from toxicity from the nivolumab, but again, we do see some significant toxicity with ipilimumab and 2 patients who died of side effects in this particular study. We've got pembrolizumab, so I think most clinicians would agree that nivolumab and pembrolizumab are pretty much interchangeable. But what this study differed in is that, so it sort of ran in parallel with the nivolumab study, and this ran against a placebo. And this was done predominantly across Europe, where adjuvant ipilimumab had not been really taken up. So this study population, again, mirrors very much the original ipilimumab study. So it's back to 3As with more than 1 millimeter through to stage 3, so 3C, but not the resected stage 4 patients. And again, patients that had complete resection of their primary tumour and nodes. The interesting thing about this study is that if patients relapse, then there is the option to unblind them, and either, if it's more than 6 months out from completion of their year, to retreat with pembrolizumab, or if they were in the placebo arm, to then go on to receive pembrolizumab. And that's quite important, and I'll talk about that in a bit more detail in a minute. So again, big trial, international study, and again, really very similar results to those that we see with nivolumab. So again, but perhaps a slightly bigger hazard ratio on the basis that we're now comparing to a placebo rather than an active alternative. Again, the toxicity very much mirrors what we see with nivolumab, with about 14% of patients getting significant treatment-related adverse events, but a lot of those asymptomatic biochemical blood test results. So this is all immunotherapy type approaches which would be applicable to all patients independently of their BRAF status. But of course, for those patients who do have a BRAF mutation, then we have an alternative treatment option with dabrafenib and trametinib. And As with the other immunotherapy agents, then this has now been tested in the adjuvant setting. So again, we're our very typical patient group of the high-risk stage 3As, the 3Bs, and the 3Cs. And again, it's a year of treatment, and this study randomized patients between a year of dabrafenib and trametinib versus double placebo tablets. Of course, these patients were all BRAF mutant, and again, a large number of patients randomized in this international trial. And again, we see clear separation of the curves. And interestingly, the shape of the curve slightly varies, and that's probably important in terms of the way that these drugs work. So we know that in the metastatic setting, then patients treated with immunotherapy, there seems to be this curve on the survival, this plateau on the survival curve, with our hope that some patients may get very long-term remission or perhaps even cure of their metastatic disease. We don't seem to see that same thing with dabrafenib and trametinib, so there's always been a slight concern that if you use these drugs in an adjuvant setting, you may be delaying recurrence rather than preventing it. And in that situation, you would expect these curves to perhaps separate initially and then come back together. And there's just a hint of that in that very early on, so in the first 12 months, when the patients are on treatment, the curves are clearly diverging, getting further apart. There's then a little period, perhaps the first year afterwards, the curves just start to come back together again. So there's clearly some patients who've benefited from that year of treatment, but once they've stopped the tablets, there's a slightly higher risk of recurrence. But the curves do then seem to separate out, so they seem to become parallel again, suggesting that there are some patients who have perhaps had an increase in their cure rate by the addition of dabrafenib and trametinib. And then this raises some interesting issues about toxicity and about treatment delivery. So relatively straightforward to take some tablets at home versus having to come to an infusion centre every fortnight or every 3 weeks. Despite that, these tablets are not entirely straightforward, so we actually see a higher side effect burden than we do with either nivolumab or pembrolizumab. So 41% of patients getting this higher grade toxicity. Fever is a typical side effect, and if you can nip that in the bud early, you may prevent admission, but nonetheless, quite a few patients might need to come into hospital as a consequence of side effects of this treatment. So we've seen a fairly similar benefit to we do with the immunotherapy agents, but with a very different side effect profile that may be more acute in the short term, but almost always resolves when you stop the drugs, compared to immunotherapy, where some of the side effects may be more long-lasting, and in fact may be lifelong. So in terms of the treatments that we've looked at, so ipilimumab alone or interferon, the toxicity probably really doesn't justify the very marginal benefit that you get from those treatments. Nivolumab and pembrolizumab seem to have very similar efficacy despite the slight variation in populations treated in the trials. Manageable side effects, but it does require regular intravenous infusions. Dabrafenib and trametinib, again, a similar magnitude of benefit, and oral agents are relatively straightforward to take, but perhaps with a slightly higher side effect burden, but that is reversible if you stop the treatment. But I think that still leaves us with a number of unanswered questions. One of those is we now know that we can effectively use these drugs even in patients who recur. So actually, is it as good to save your treatment for when a patient recurs rather than treating everybody? So by using adjuvant therapy, we're treating a big population of patients who may never have needed that treatment. Can you get the same benefit if rather than treating everybody, you wait and select out those patients who are going to recur and treat them at that stage? And in some ways, the pembrolizumab trial will help to answer that, because the patients in the placebo arm then have the option to receive pembrolizumab at relapse. Mark's talk about biomarkers to try and predict very early recurrence, and then would there be a role for saving your adjuvant treatment until there's some sort of molecular readout that would suggest that patient would particularly need treatment? Of course, there are other treatments coming through, in particular ipilimumab and nivolumab, although with quite a high toxicity profile. Will these combinations have additional benefit over the agents that we've used so far? And when are we going to see routine use of this available from the NHS? I think we're hopeful that that will be the case by the end of the year. So I'm going to stop talking about adjuvant therapy there. And just the final thing I'd like to talk about is the metastatic study that Neil mentioned earlier on. So we're through the first stage of getting some funding to run a trial looking at how we're going to manage the toxicity of colitis for patients treated with combination immunotherapy. There's been lots of talk about patient involvement in trial development, and that's something I'm really keen to encourage, particularly for this trial. So we've had a select number of patients involved in developing this protocol, but if there's anybody here who has experienced immunotherapy-induced colitis and would like to get involved in this project, then please do let me know, or pass your details on to Imogen, who's got my email. Thank you.